Luncheon with the Experts. I am going to hop over to Facebook, make sure the stream is indeed broadcasting, and we will get the show started. I always love to see the numbers. As soon as we start, there's already a few people waiting and joining, which to me is a good sign. There we are. We are indeed live. Got a couple people, early joiners. Oh, we're jumping up quickly. Well, let's not keep the people waiting. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and a writer, among a few other things. But I've been working with the foundation for over 10 years. It is 2023, so I think it's about 12 years now. And in that span of time, we've created hundreds of videos, all kinds of video content, a live video series like you're going to watch today, patient-centric documentaries, which are pinned to our Facebook profile. We did 5 of those last year, treatment-based videos, conference and event videos, literally hundreds of videos, but all with one singular mission in mind, and that is to raise awareness and education about neuroendocrine tumors. That is what we're here to do today. Now, I think the value of the show is really twofold. One, the information you will get from our guest, and two, the community that one is inherent to the net sphere, the net community already, but also I think we've done a good job of cultivating it here within the show. And so you see people already signing on and saying where they're from. Good morning from Alberta. Good morning from Richmond. If you're new to the show, welcome. And I encourage you to reach out, introduce yourself, tell us where you're from, embrace the people in the comments section, i.e. the net community, because they will embrace you back. This community is extremely strong, extremely supportive, and I'm grateful to be a part of it, even just from my kind of outside position. Now, before we get going with the show today and introducing our guest, we would like to thank Ipsen Biopharmaceuticals, the presenting sponsor. We couldn't do the show without them, but we also have this disclaimer from them before we start. That is, the opinions expressed by the guest presenters today, as well as the questions that you all, the audience at home, have asked, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views or opinions that are provided in today's presentation. So here's the takeaway. Audience members should not rely solely on the guidance and information or the opinions and information expressed by the guest today, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. That is really the crux of it. That's the takeaway. We don't know your specific case, so we're going to give you general advice and hopefully some answers to your questions. Take that advice and those answers back to your home team, which does know your specific case, and make the best plan and path forward for you. I'm not a medical expert, but if there's one thing I've learned in 10 years of working in this field, is that each case of this disease is unique, and therefore each plan and path forward is as well. Okay. Today, I'm excited to have back to the show for the first time in almost 3 years. We've been doing the show for almost that long. In July, it'll be 3 years. Dr. Heloisa Soares, welcome back to the show.
Thank you. Nice to be here with you all.
Yeah, I think you were here the first time maybe in September 2020. So we were just a baby show getting started at that point. A lot has happened since that point in the world and in the world of neuroendocrine tumors. Before we get into that, because I know we're going to touch on some of that today, tell the folks at home who might not be familiar with you and what you do, where you work, what your specialty is in the net space.
Yeah. Hi, everyone. So my name is Heloisa Soares. I am a medical oncologist who focuses in GI oncology and neuroendocrine cancers. I work at the Huntsman Cancer Institute at the University of Utah. I have been here for a little bit more than 3 years. And I see patients in the GI clinic, but I see patients with all different neuroendocrine cancers, particular neuroendocrine tumors and the neuroendocrine carcinomas. I'm also the co-leader for the GI oncology clinical trials research group. And since last year, I became the medical director for clinical trials here at Huntsman. So I help the operations of having clinical trials for Huntsman, which is very important to me.
Absolutely, and I think it's also very important to our viewers and our listeners. So, folks, that'll be a good opportunity, I think, for you. I know lots of people are interested in clinical trials, especially with all the activity. When we ended the show last year, we took a month or two off in October, but obviously, as you know, Dr. Soares, there's been quite a bit of activity in the net
Yes.
space, in the research space, specifically in the past year and ongoing right now. So I know there's a lot of interest. So, folks, I'm excited to hopefully answer some of those questions for you as well. Just a couple of rules of engagement for everyone watching at home to help us do our job better, which is, of course, to serve you. I mentioned this already. We or Dr. Soares most likely, don't know your specific case. So try your best to answer or ask rather your questions in generic ways that aren't super dense with your specific, the specific details of your case. It's very hard to do that in this format. And you can ask as many questions as you want to. So if you ask one that kind of gets you a little bit further down the road, we're happy to field as many as we can. You can ask them as many times as you want. We won't get to all the questions just because we get so many, but that's why we keep the show going on. That's really the fuel that keeps it going on. So please be patient with us. Dr. Soares, before we started recording, you also mentioned that you'd be willing for people, depending on the question, to reach out to you as well, which I think is very gracious of you. So this is our job to try to get you the answer. We're going to try to do it in today's show. Don't be discouraged. As I said, continue to ask us questions, but also continue to lean on the community, because a lot of the shared experiences and stories within the community, I find to be extremely helpful for patients as well. So go ahead and start sending in those questions, and we'll start answering them. Dr. Soares, before we start taking questions, talk to me. We talked about this briefly the other day about the Destination Net Care program and what's been going on there at the university.
Yeah, so I'm super happy to share that because it's something that we have been working here at Huntsman and the University of Utah for some time. So the University of Utah has a project that's called, or a program that's called Destination Care. And the goal is to really facilitate the care and improve the care of patients from the whole region and even nationally, right? So if someone wants to seek care here, we can help to coordinate. Sometimes we can have help with travel. The program has been awarded some airplane tickets that they can be used to patients that need to fly in. And I thought that was great. And we got the assignment as NET being one of the new destination care programs. And then we'll be working really hard in improving access to net care for the region. Stay tuned for a new website that's going to be available to facilitate patients' understanding of the services that we have. We will have someone dedicated to schedule patients with neuroendocrine cancers and facilitate all the navigation of the journey. Also, we already have tumor boards that talk about our NET patients, but this is going to expand and even have a more dedicated team. So I'm very excited that this is something that the region needed in the West, and we serve University of Utah, and the Cancer Center is particularly focused in serving the 5 states here.
What are those 5 states?
So it's Utah, Nevada, Idaho, Wyoming, and Montana.
Yeah, this is so important too, because I know from a variety of kind of rural pockets around the country that it's a real struggle for NET patients to get to an area that really specializes in this disease. So I think that's very important. You should be excited. You should be very proud too of your institution. But I think that's very great for the patients because your reach is so broad. So I think that's awesome news. I appreciate you sharing that with us.
Yeah, and we do offer a lot of telehealth visits, and especially to facilitate getting the initial access to care. Right. So many times we see the first visit as a telehealth just to get to know the patient, see exactly what the patient needs, and then try to coordinate that moving forward. I do think it's important at least once a year to see patients in person, so we can do physical exams and few other things that are that telehealth is
Gotcha.
hard to accomplish. Also, one thing that sometimes patients don't appreciate is that having scans, having the imaging studies done at your own institution or the institution that your team is, it makes a lot of difference because we know exactly how the scans are done. Is easy to discuss. The protocols that we use to make sure that the imaging is good quality is important. But we are really very flexible in terms to try to work with patients that are far away and don't have the capability to come for a visit. We do need patients to have good quality internet because sometimes one thing that I face is that we're like, yeah, we're going to do a telehealth visit, and then unfortunately patients are in a region that the internet connection is not great, and that becomes challenging to have a productive visit.
I understand. Technology sometimes can still
Yes.
get in the way. It can open a lot of doors, but sometimes it makes things challenging as well. Speaking of technology, folks, one tool that I haven't mentioned yet that I think is helpful for those at Facebook, especially when you're trying to listen, take notes, type a comment. If you're on Facebook, which the mass majority of our viewers are on, if you look at your screen that you're watching the video on, at the bottom right hand corner there's kind of a list of icons, of different icons. You can control and make it full screen. You can elevate the volume, and there's one that says CC on it, and CC stands for closed caption. It's just a way you can put subtitles on the bottom too. If you're watching this at a place where it's loud or you're at work, that way you can read along with it as well. But it just helps our viewers, and so that's a little tip I wanted to give you there too, so you can see the words at the same time. Dr. Soares, we have lots of questions coming in already, so I'm going to go ahead and get to some of those. The first one comes from Simran. Simran says, what can I do to boost appetite? Because after Y90 treatment, I've completely lost it, and now that has also brought along weight loss, which they're concerned about as well.
Yeah, great question. And again, I don't know the specifics, and I don't know how long ago was the Y90 liver embolizations, independent of the type. We have
Sure.
blood embolizations, chemoembolizations, and radioembolizations with the Y90 can cause a lot of inflammation in the liver, and that can translate, especially in the first several weeks, with significant fatigue, the lack of energy, and sometimes patients might feel that they don't have the appetite. So if the procedure has been done in the last month or so, I can imagine that hopefully this will come back. If not, you really have to work with the provider, because with your care team, to see what are the medications that might be able to be provided to you to boost your appetite. There is a few things that can be used. There's medications that are particularly focusing in boosting the appetite. Some of the antidepressants that are in the market, one of the side effects is actually increased appetite. So we use one of them a lot for the appetite purpose. There is also a medication that's called Marinol, that is essentially a high concentration of THC that can also help to increase appetite. Sometimes even steroids, high dose steroids for a short course might help with increasing appetite and energy. So there's a few tricks that can be used. And then I think discussing with the care team to understand exactly the nuances might help to decide what's the best strategy. But just few general options there.
Thank you so much. And thanks for your question, Simran. And, next question from Pat. This is about the clinical trial with cabozantinib. The question is, have you seen any major shrinkage in the liver and pancreas with that clinical trial drug, cabozantinib?
Yes, great question. And if you are on the trial, thank you for participating. I really think it's an important study. So just for the folks that are in the call, cabozantinib is a TKI that helps one of the things that helps to address is the blood vessels in the tumors. And it's a pill that you take once a day. And based on the phase 2 data that was published previously by Dr. Jennifer Chen, who is at Dana-Farber, that there was some shrinkage. There are a significant number of tumors that shrink more than 30%. For the phase 3 trial, the trial is still ongoing, so we don't have the data. But based on the phase 2, yes, there's a percentage of patients that will be able to see substantial shrinkage on the tumors, what's called partial responses, that when we pick up the baseline imaging, and then you see that the tumors shrink more than 30%. Having said that, we have seen that many patients will have shrinkage, just that doesn't hit the threshold of the 30% of shrinkage to call it a partial response. But we see a lot of small changes in shrinkage as well. So if your care team discuss a consideration for the capacity trial, please consider enrolling, because we as a community are very close to finishing the accrual for this trial. I think we need less than 100 participants, and that can potentially lead to another drug option for patients, because cabozantinib is not currently a FDA-approved medication for patients. But if we finish this trial and the trial is positive, that can hopefully be an option, another option. So clinical trials.
Yeah, absolutely. Thank you, and great question, Pat. Thank you. Next question from Nancy. It's about side effects with sandostatin. And the question really is lanreotide, this is actually a common question, is lanreotide the same drug with a different name or manufacturer? And then the real question is, would lanreotide likely have the same side effects or side effect profile as sandostatin? So can we just do a little fundamental kind of explanation of those two options, and then if there's any similarities or differences?
A great question, Nancy. And so lanreotide, I call it as a cousin. So both of these drugs are called somatostatin analogs. Octreotide is the sandostatin that has been in the market for a little bit longer. It's an older, quote-unquote, drug. And lanreotide, or somatostatin is the commercial name, is a little bit younger. They have different ways to be delivered, right? The octreotide, or the sandostatin, you do is an intramuscular injection, and the lanreotide is a deep subcutaneous injection. So you can see the difference in the needles. They serve the same purpose. They are both to control symptoms, functional symptoms related to the tumors, and they are both can be used for tumor growth control. In general, the side effects are expected to be very similar, because again, they're the same class of medications that are the somatostatin analogs. Having said that, depending on the specific side effect, one can switch from one to the other and see if there's a difference. Another thing, depending on the side effect, is to decrease a little bit the dose and see if that helps. I had patients before that were on sandostatin, and I switched them, and then they felt that the side effects were a little bit better. And in terms of side effects, fatigue, bloatness is another one. Some patients have arthralgias, which is something not very well described with this, but that can help also if we change or decrease the dose. So talk to your care provider. Might be worth it to exploring the alternative and see if it will help with your symptoms. It's not going to affect you your treatment per se in terms of affecting or decreasing your chances of having stability of the tumors because you're switching. I don't believe that there is a difference on that.
Got it. Hey, thanks, Nancy. Appreciate your question. Hopefully that helps. Next question comes from Gladys. Gladys says, I had a net removed from my stomach in 2010. I have had an EUS, endoscopic ultrasound, and the last one showed over 20 sessile polyps in the stomach. How concerned should I be, and what would be the recommended path?
Okay. So Gladys, your care team explained to you that when we find a neuroendocrine tumor in the stomach, we have to classify what they are, because there's type 1, type 2, and type 3 carcinoids. Most of the time, patients have type 1, which is the one that is a very chronic condition. It, most of the time tends to be not life-threatening. If a patient has a type 1 neuroendocrine tumor in the stomach or several, because they tend to see several, and I don't know if these 20 polyps that you saw later on were biopsy, and some of them were confirmed to be neuroendocrine tumors. But if you have type 1, you most likely has associated atrophic gastritis of your stomach. And the way to control or monitor is just having the endoscopies, and plus or minus the US every 1 to 2 to 3 years, depending on the sizes that you see. And then when they start growing a little bit, you just scoop them out. But you don't have to go to any larger, for most of the time, any larger gastric or stomach resection. Type 2 is a little bit different. Patients that have what's called gastrinoma, they'll have a lot of heartburn and diarrhea associated with that. And typically you'll find a primary tumor in the duodenal or the pancreas. And type 3 is when you only see typically one isolated neuroendocrine tumor, and your gastrin levels are normal. You don't have a history of gastric atrophic gastritis. And that are the ones that have a higher chance of spreading to lymph nodes and other organs. But for the type 1, again, if your history of having multiples and then they just keep coming back, the chances of that causing any life-threatening issues, such as spreading to other parts of your body, are minimal, less than 5%. So yes, to answer, in after all this big explanation, if you have type 1, just keep continuing your surveillance endoscopies with your GI doctor. And if the tumors are a little bit bigger, sometimes more than 1 centimeter, they might decide that to remove them. So that's a conversation to have your GI team. What type of gastric neuroendocrine tumors do I have? Because that will make you understand better how worry about life-threatening consequences of your tumor and how to manage moving forward.
Got it. Thank you so much. Appreciate your question, Gladys. Next question from our friend Karen. Hey, Karen, good to see you. I just read from the makers of Afinitor drug that should not be given to patients with carcinoid syndrome. My oncologist has been offering this to me, and I have carcinoid syndrome. So if she heard that, and then her oncologist offered that, she's a little confused, it seems. Do you have any insight on that?
Yeah, so Afinitor is actually the drug name is everolimus. It's a drug that has been approved for patients with neuroendocrine tumors. And the difference is that there were 3 big studies that were done. One in pancreatic neuroendocrine tumors, and one with all of the patients that had GI or lung that were non-functional. And the study that has been done on in patients that had midgut or small bowel tumors and carcinoids, initially there was a concern that the survival could be not as good for patients that had the Afinitor, but with more long-term follow-up, I think some of this worry has been has decreased. Mm-hmm. So we use it. We still use it. I think it's just that we are aware that perhaps the benefit might not be as long as in patients that don't have carcinoid syndrome, but we still have to get more options in the pipeline. So it's certainly something that I continue to use in patients with carcinoid syndrome.
Okay, good to know.
For tumor control, and let me just clarify, because every time that we think about patients with NETs, are we using the treatment that we have for tumor control or for symptom control? And we can use everolimus for tumor control.
Got it. Thank you so much for that thorough answer. Hey, Karen, I appreciate your question. Hopefully that helped. Next question from Sujata. Hope I'm pronouncing that correctly. I think this is the first time I've seen you, so welcome. Sujata is joining from YouTube. So this year, folks, we're using a new software, and certainly primarily our biggest audience is here is on Facebook Live, but we're actually able to broadcast to YouTube, Facebook, and Twitter all at the same time. So for those that don't have Facebook, they're able to join us via YouTube, so you can pass that information along too. So welcome Sujata from YouTube. The question is, can primary mesenteric nets be cured by resection alone?
Yeah, so I think it's interesting you say primary mesenteric mets. Typically starts in the small bowel, and then the patients develop this mesenteric metastasis that are next, hopefully next to the primary tumor. So, well, if you can resect your mesenteric tumor and you find the primary, or if you don't find and you feel that you resect everything, I think your chances of having a very durable remission or potentially cure do exist. So the issue is that when the surgeons go, they will remove that particular large tumor, and they will tell you that they will run the bowel, and you put the bowel on your fingers if you're having an open resection to feel if there is any tiny little tumors that can be identified in the gut. And this is important because we know that particularly for the small bowel, even I call it bastards, even tiny little bastards that are like 5 millimeters can start already spreading to other places. So that's what's important to try to find where it started from.
Got it. Thank you. Hopefully that helps. And if you're still on the call and you have follow-up questions, please send those along as well. Next question from Cindy. There's a lot going on here, but I want to try to help Cindy. The question is, she's having more elevated carcinoid syndrome symptoms where the heart races, feeling lightheaded, virtually the entire body flushes, and I have trouble breathing. GP says to lie down, so blood pressure gets back to normal. Oncologist said blood pressure is plummeting due to, I need to remove that so I can read it, due to all the vessels dilating. Chromogranin A numbers are very high. Does this indicate tumor burden, tumor mets in the liver, bones, etc.? And also finished PRRT last December. So
Yeah. So, Cindy, correct?
yes.
Yeah, Cindy. I don't know the specifics, and you probably is planning to have a scan or just had recent scans. And if you're having a lot of carcinoid syndrome symptoms, despite the fact that you just received PRRT, and if you see a lot of disease in the liver, one thing that we do is for symptom control, consider liver-directed therapy or embolizations, because they can really help with symptoms. Even if your tumors are not increasing in size on the scans, they might, for whatever reason, becoming more functional. And when one way to control that quickly is with liver-directed therapy. We know that patients that receive liver-directed therapy can have almost by the next day response in terms of symptoms, and they can be up to improvements somewhere in the literature between 30 to 80%. That's one way to control your symptoms if you do have a lot of disease in the liver. Obviously, other strategies to help with carcinoid syndrome symptoms are related to increasing your somatostatin analog. If you are on 30 milligrams of octreotide/sandostatin, you can discuss with your team about increasing that. If you are on lanreotide, now we know that's safe based on the Clarinet Forte 2 study, that you can do lanreotide every 2 weeks instead of every 4 weeks. Your issue is if with sounds like blood pressure, but if someone is having more diarrhea related to the carcinoid syndrome, and we know that's carcinoid syndrome related diarrhea and not a completely different diarrhea, either because of your somatostatin analog or something else. There's a drug, telitarstat, the commercial name is Shermello, that can be also used. So discuss with your care team how much disease do you have on your liver. Is there worth it to considering liver embolizations to try to cool off all this hormone secretion? And I'm sorry that without more specifics on your case, it's hard to give you a more in-depth discussion. But you can always email me later. and we can chat offline.
Absolutely. Thank you so much. I appreciate it. So, and listen, when doctors offer something like that, I would take them up on it. So, we'll try to put Dr. Soares' information in the chat box, but she's pretty easy to find via Google as well. Let's keep moving on. We are just a little past halfway through, folks, so plenty of time to get to lots of questions. Ron says, in 2019, I had 2 primaries in the lower bowel. They metastasized to the lymph nodes in the liver. I've been NED since surgery. Had a CAT scan every 6 months. Next scan's coming up soon. The question is, do you think an MRI would be more appropriate to check the liver?
Great question. And first of all, congratulations on being
Indeed.
NED. That's the best news that we can share with patients. And sometimes I walk into the room before I start talking anything else, because I know that everybody's so anxious. I say, scans are okay, so now we can talk. Depending on how are you doing your scans and if you have fatty liver or not. So MRIs might be a little bit more sensitive. So in general, we know that MRIs might be 10% more sensible to pick up disease in the liver. Obviously, you have to see which machine are you using because, depending a little bit of some of the quality of the skin. But as a short answer, yes, MRIs could pick up a little bit more of disease. But a very good CT multi-phase of the liver, which really get the arterial phase, should be also excellent to catch that. So go back on your report and make sure that there is a dedicated arterial phase. And that will give you peace of mind that hopefully there's nothing being missed on the CT scan. Some folks call it triple phase CT, dual phase CT, CT pancreas protocol, and you say it's the same timing of the contrast for a dedicated pancreas protocol. You will have the same arterial phase that we can take a good look in the liver. And sometimes patients that have a lot of fatty liver disease or steatosis, it might be a little bit harder to have a good quality imaging of the liver. So when patients have that and they come to see me, I really try to change them to MRIs just because then I know that I'm not going to be missing anything from that.
Got it. Thank you very much.
I
Next question.
Rain,
Say it again.
You can stop me. I think I talk too much. So
no. You know what we call that here at the show, Dr. Soares? We call that being thorough, and we appreciate that here. So you are here to talk, my friend. Next question from Migdalia. I hope I'm pronouncing that correctly. Let me know if I'm not, because it's important to me to get that right. Question. My husband was diagnosed in 2013 with stage 3 or 4 carcinoid cancer metastasis from the terminal ileum, lymph nodes, mesenteric wall of the abdomen, and the liver. He had a bland embolization to the liver, and in 2013 became necrotic, but now it's growing. So does this mean the sandostatin is not working? Or could this mean the sandostatin is not working?
Yes, potentially. If he has been on sandostatin for that long and now the disease is growing, yes, I think it might be time to think about a different treatment strategy or addition of a treatment strategy. But I just want to clarify one thing that is something that sometimes I spend time with patients is looking at the report and saying, there is increase in the disease, and then that means that the disease increased by 5 millimeters in a very long period. I wouldn't necessarily call that clinically significant progression. So there's always a little bit of a difference between what the report says and when you look at the imaging of how much this actually means, right? Because if someone has very little disease in the liver and the disease grew just a little bit, I don't think it's worth it. And that's a discussion with the patients, of course. But do you really want to change your treatment strategy for something that's not really impactful in the bigger scheme of things, right? Because just a little bit of increase it's not going to be what's going to put you on a truly immediate life-threatening situation. So perhaps just stay with the same treatment for a little bit longer before you have to use your next treatment strategy. Having said that, if now the tumors are growing more in a more rapid way or in a very sizable way, then absolutely it's time to change treatment strategies. We know that liver embolizations are not something that tends to that are considered curative, and hopefully they can keep patients on a longer remission and a stabilization of the disease. But if we expect that eventually the tumors will start growing again, and then the discussion is, okay, if it's something that is actually actable, then we feel as a team that needs to be taken care of, is going back to more embolizations the best strategy. If things are only in the liver, is that a consideration for a resection? I am a huge fan of considering debulking surgeries for the appropriate patients. It's not for everyone. So that's why it's so important to have a truly multidisciplinary team and have a team that really understands this disease to figure out what's the best strategy for you. Because what's right for you might not be right for the patient sitting next to you in the waiting room.
Got it. Understood. Thanks for your question. Hopefully that helps. Next question from Fred. Is there some information that a thoracic MRI can give about a suspicious pulmonary nodule, 1.3 centimeters, possible carcinoid, regarding growth and physical appearance? I'm concerned about radiation from any type of CT scan, which is a common concern.
Yeah, I know. I have the discussion sometimes with patients, and because they're afraid of the concern about the radiation. And MRIs of the chest, we feel in general have a less use. I don't know how much you're really going to learn from having the MRI of the chest. So I think probably just discussing with your care team, perhaps spacing more the CTs, it will be an option. I think if you absolutely, decides that you want is not something that you want to go through, I think your team might decide that, okay, let's try it. I'm not sure even from a practical standpoint that your insurance will be willing to pay for that, right? We can do all sort of things, and then in the end of the day, someone needs to pay for that. I will encourage you to discuss with your team about the CTs one more time, perhaps just space them. Having up to 3 scans a year is not something that is very detrimental in terms of risk exposure, particularly if you're older. Obviously, if you're a child, that's a different story. But as we get older, some of this issues with radiation concerns sort of become less pressing.
Got it. Thanks for your question, Fred. Next question comes from Tom from the Wisconsin Neuroendocrine Cancer Connection Group. So Tom is asking, he says, many NET patients manage diarrhea due to tumor, surgery, short bowel, or syndrome. What is your opinion about using Interade to manage this? Is it Interade or Interade?
Oh, I say Interade, but maybe
okay. I wasn't familiar with that,
wrong.
but you knew exactly where we were going. So
So I use sometimes in patients. So is a liquid solution, is amino acid solution. There is no there's not a lot of sugar that comes along with it. So it's not a nutritional medication. It's really just for hydration. And there is some studies that are ongoing. And Dr. Nanu Das, when he was in Vanderbilt, he had a study with that. Then Dr. Aman Chauhan in Kentucky had a study with that. And there is some encouraging data that might help with diarrhea. The studies that they did were with carcinoid-induced diarrhea. But I have used it on a patient that really didn't want to take any more drugs. And then it really helped her for some time. So anecdotally, I think is is a good option to try. If you want to add something else and you don't, these strategies, that medication strategies that you use didn't work, or you want to something else, it's not, as far as I know, it's not covered by insurance, so there's a cost involved with that. But I don't think there's any downside in trying, as long as you consult with your care team and make sure that all other strategies that have been recommended are being used. It's just a hydration tool to felt that also might work in decreasing diarrhea. And what has been more studies with carcinoid syndrome diarrhea.
Got it. Thank you. Appreciate your question. Tom, good to see you again, my friend. Wendy says, will lanreotide or octreotide help people without peptide receptors?
Excellent question. I typically do not put patients on lanreotide or octreotide if they do not have imaging that shows that they have somatostatin receptors. I know that some of my colleagues, if it's negative, they might still ask for staining the tumors and see if they have or not, which is a whole nother conversation with a pathologist in terms of which antibody you should use to stain your tumor and so forth. So I typically don't, unless I don't have any other options. But if I cannot get a dotatate PET-CT on a patient for whatever reason, including the fact that many states Medicaid does not cover that, and you can get me talking about that for hours, because I'm very passionate about patient access to care and how folks that are non-doctors can dictate how we take care of our patients. But so if you don't have access to a dotatate PET scan to and you have very clear a very clear diagnosis of a well-differentiated tumor, I will put you, or I will recommend a somatostatin analog with a little bit probably of a shorter scan, because then if the tumors are growing, we'll know sooner than later that that's not a strategy. Also, oh my God, I lost my track of thought. But so no, if I know that the patients don't have it, I tend not to use it. But sometimes we just don't have the information. In that case, I will use it. If someone has a lung carcinoid and we do the scan and it's negative for a receptor, I will not start this patient on lanreotide or octreotide. I should say that about 90% of the patients with a GI well-differentiated tumor will have positivity, especially at the time of diagnosis, will have positivity on a dotatate scan or an octreotide scan.
Got it. Next question is from our friend Sarah. Hey, Sarah, I have neuroendocrine tumors on my skin. Biopsies show Ki-67 20% of 2 of these skin tumors. Do you know anything about these tumors? She also has small intestine, bone, liver, skin, and she says lower she's on Afinitor and octreotides. Any knowledge or thoughts on
Yeah,
skin?
we sometimes see the subcutaneous nodes that you see in the skin, the bumps. I think it's more commonly seen with the lung carcinoids, and they can be very tender. So there's not a particular dedicated strategy to take care of these lesions. And what happens is if one of the lesions starts to grow more or is tender or painful and uncomfortable for the patients, we just ask dermatology or plastic surgery to scoop them out and remove them, because it tends to be a very simple and superficial resection. But I don't have any other special tricks or particular strategies just for that.
Got it. Thank you. From Lydiana, how common is metastasis to the bones, and how long does it take to get there?
Unfortunately, it's common, and I think with the better scans that we're doing with the dotatate scans, we're seeing more of them. Some patients at the time of diagnosis, we already see them. Some patients with time, we end up seeing them. And when I tell the patients, is that take a deep breath, because if there's just a low volume of this bone metastasis, that is not what is truly life threatening. It can be painful, and there are strategies to help with the pain related to that, particularly if the lesions are a little bit bigger, such as we can do focal radiation for the purpose of controlling the growth of that particular lesion, and also to help with the pain. But if you have tiny little lesions in the bone here and there that are not causing any trouble, we just monitor them, and I don't think there's any indication to do anything more just for them. There's a whole discussion whether or not patients should be on bone strength medications. I have these discussions all the time. We don't have dedicated data about bone strengthening medications for neuroendocrine tumor patients. So I think it's a conversation between the amount of bone disease that we see, the overall health of the bone that the patients have, and whether or not the patients understand some of the side effects and are willing to take it. So it's a little bit of a conversation, but to answer your question, we see them very commonly. But there's no timeline, because we can see at the time of diagnosis versus much later.
Got it. Thank you. Folks, we got just a little bit less than 15 minutes left. I want to say a couple things, or bring attention to a couple things. One, the numbers are looking great. Appreciate everybody in attendance. Two, I'm seeing the conversations going on within the community. Dr. Soares, unfortunately, you can't see this, but you guys are showing exactly what I talked about at the beginning of the program about the support and the sharing of stories and experiences within the community. And I just see a lot of that going on today. And I just wanted to call it out and give you all props as well. I love seeing that and seeing all that communication. Now, I have a question that I can field. Loretta says, where can I get information on carcinoid lung tumors, please? And a few comments down, we have added one of our videos on that. But also, Loretta, our resident lung expert that we have on the show quite often is Dr. Robert Ramirez, who will be on the show in April. You don't have to wait that long, because we've also had him on the show many times. So if you go to either our YouTube channel or here on Facebook under the videos tab, you can search for his name, and all of those are pretty much all about lung nets, because that's his specialty. So pretty much the whole hour will be dedicated to that. And we've also done a video on lung nets, which we've added in the comments. So hopefully that helps, and he'll be back on the show in April 13th, I believe. Okay. He's awesome. Is that what you said? He is indeed very awesome. He's often watching the show, sometimes lurking around in the comments, but we love him very much here at the foundation. He's a great guy, great net specialist, very helpful. But we still have some time, so let's try to get to as many of the remaining questions as possible. But yeah, I love all the comments going back and forth. We have a question from Jim, and he kind of says that as well. So many good questions and responses today. I agree, Jim. Are there significant dietary suggestions with nets, as well as some symptomatic relief from lanreotide side effects? We've had some similar questions to this today.
Yeah. Oh, that's $1 million question, because what my work, I know, and I wish we had more studies or for that, because I really think we need to have more nutritional studies in nets, and there's some conversations about trying to develop recommendations on that as a society. But what I tell patients is, number one, if your GI symptoms or nutrition is related to the shots, like you're having side effects, and what is the side effects? They typically are related to pancreatic enzyme deficiency. And what I say is that lanreotide or octreotide is a hormone, and then can affect different organs. And then in the case of the pancreas, can be, I say, make the pancreas become lazy to produce the enzymes that help you to digest food. And how is that translates to not having enough enzymes to digest your foods, like that the pancreas produce? You have bloatness, you have a lot of bloating after you eat, which can be like the discomfort, pain. You will have mushy stools, sometimes oily, they can be foamy, you can see undigested food, sometimes if it's that severe, you can start losing weight. And then you have to see which foods are triggering that. Most of the time are fatty foods. And one of the ways to navigate that is to supplement your your pancreas with pancreatic enzymes deficiency. The two commercial names for that are Creon or Zempap. They can be expensive. Patients have different copayments, so many times they may or may not be able to afford it. But that can be extremely helpful for patients to be receiving this pancreatic enzyme supplementation that will help with the symptoms. And after, if you're losing weight because you're not absorbing the food right, because it's fasting, it will help you to regain your healthy weight. That's one. In terms of things that cause a lot of discomfort, is really working with a nutritionist and writing a diary to see what is a trigger. There are foods that patients know that will trigger a lot of digestive issues. There are foods that will trigger carcinoid syndrome. Chocolate, tomatoes are some of them. Banana. So inquiry if there is a nutritionist on your care team, and then really work with them, because having a nutritionist that really understands the disease and works with you will make the whole difference.
Got it. Thank you. Next question from Ron. I receive a Sandostatin injection every 30 days. It seems to run out in terms of effectiveness after 3 weeks. So
Yeah.
do you know if it's possible to receive an injection every 3 weeks? Would insurance pay for this? Yes,
Yes,
please.
so happens all the time. Patients say it's running out. I feel like I'm feeling again. It makes me, it's very hard. So this is a very common conversation. So there's two things that can be done. Well, I mean, I'm not taking care of you, but in general speaking, number one, if it's just for a few days, you can do the short-acting octreotide. That's the rescue shots, or you can bump and request that your injection should be every 3 weeks. Most of the insurances will allow for that, as long as you have enough justification. And there's papers published about increasing the frequency or the strength of the medication for that. So most of the time is being okay. Occasionally, I had problems with Medicare with some of the supplements that did not approve, but with enough justification, should be okay from the insurance standpoint to do that. So talk to your care team. If your care team is on board, that's what's going on, they probably will try to switch to 3 weeks, put the orders for the insurance, and hopefully everything will be okay and you'll feel better from that standpoint. But very common, you're not alone.
Thanks, Ron. Appreciate your question. And a few other people have commented on that as well. From Sarah, I have tumors in the liver and mets to the bones. I've been receiving lanreotide injections for 3 years and had my first PRRT in January. So far, my symptoms are being controlled and I've been feeling well. That's good to hear, Sarah. I just recently noticed that I've had some uncontrolled tremors in my left hand. Could this be due to the disease in the liver?
I'm thinking in general,
Right.
and not specifically about your case. I will really consider this a diagnosis of exclusion. So I think you should, especially if it's just one hand or one, I think you should talk to your care team, and I think you probably need additional workup, either by your oncology team or your primary care, or depending on the conversations, consider extra specialties, because that's not something that we typically see as described in regards to liver burden of disease or side effects of PRT.
Got it.
Sorry, I don't have more answers. I just think it needs to be more investigated further.
For sure. Ruby says, I've been having a lot of gallbladder pain after eating. Is it time to consider having that removed, or does it depend on lab results?
Well, we know that patients that are on somatostatin analogs for some time are at a higher risk of developing gallbladder stones. So what you're describing might be very typical of someone that had stones in the gallbladder, and your gallbladder might need to come out. I think ultrasound or CT scans might be important to see if you have that. and then discuss a consideration for gallbladder resection. But go back to your scans reports and take a look if they mention any stones in the gallbladder, because that could be the issue. And then yes, if it's the issue, you can discuss with your care team about consideration for surgery.
Got it. Thank you. Just a few more minutes, but we're going to get to as many as we can. Next one from Mandy. This is a big one, but I think it's just important. Mandy says a lot of people in the net groups say this cancer always comes back eventually, despite reported statistics. It looks like most people here have dealt with metastases. Do you have or know of any patients who've, after a long-term surveillance, not had recurrence?
Yes. First of all, hi, Mandy. Thanks for joining. And I think she knows why I'm saying hi. We have to follow patients for a long period of time. I typically follow patients for a minimum of 10 years. Especially when we look at the GI nets, we know that there is a chance that the tumors will come back in the first 3 years of about, especially if you have positive lymph nodes or any high risk features, of about 20 to 30%, and then past that, it slowly goes. But there are patients that the tumors will never come back, and so yes, at least a good probably 40 to 50%, and again depends on quoting the stats. It really depends on details of your particular tumor that was resected. But I do have patients that have been in surveillance for a very long time, and the tumors have not come back. Also, I'm just going to put a plug. There is a study from the NCI, from the National Cancer Institute. That's a national study for which I am the study chair, looking into giving chemotherapy for patients after the resection of a pancreatic tumor that has high risk features for recurrence, to see if giving the chemotherapy after the resection of the pancreatic neuroendocrine tumor will decrease the odds of the tumors to come back. And we use a 3 years mark of decreasing the recurrence rate. So if you just had a recent pancreatic neuroendocrine tumors resected with up to 4 METs, you can have METs or non-METs as long as they are less than 4. Consider discussing with your care team this trial, because that will help to answer the question: is there any role to giving any more treatments, what's called adjuvant treatments, after the resection of the tumor, to decrease the odds of the tumors coming back? And we're starting with pancreas neuroendocrine tumors. And I can share something
Please.
personal. My brother is a recent survivor of neuroendocrine tumor that was just resected, and we are going through the same. I know it's an irony of life, but
Right.
we are going through the same stress and anxiety that every scan. We want to make sure that he has a clean scan, and so far he has clean scans, and I hope he'll have clean scans for the rest of his life.
Well, I'm sorry to hear that, but I am happy that you're on his team fighting for him. And folks, this is my point about this community. It's not just the patients and caregivers and support group leaders. It's the experts and the specialists and doctors as well. So this is a case of Dr. Soares fighting for her family, fighting for you as well. And I know she's very passionate about it. I wanted to, I saw a comment I thought was very sweet. Nancy says, "Hi, Rain. I was in broadcast news for 20 years, 4 of those as a talk show host. I just wanted to let you know how impressed I am with your hosting abilities. Well done." My goodness. I don't like to take any kind of shine because the shine is on our guest, but I'll take this little bit, Nancy. I thought I was going to get a criticism. That's my ego, my insecurity coming in there. I was like, oh no, what's she going to say? Thank you very much. That means a lot. Dr. Soares, before we go, I think you just led into a perfect question for us to end on, speaking about your brother. I'm often interested in the answer to this question from our specialist of what you would say to a first-time patient that is facing this disease, that is confused, most likely scared. So I will change it a little bit and say, what was the first advice that you gave to your brother?
Yeah, I told him that I was going to get the best possible team behind him, and that we will work on each problem at a time and deal with whatever comes next. So for him, the first problem was like, we can we resect all his tumor? Yes, let's resect it. And then now is like, is there any treatments that we should do after his resections? The answer right now is no. Maybe that will change depending of how the trial that I mentioned before and maybe other trials. And now is, how often should we do scans to make sure that he is doing well? And then I tell him, in the worst scenario, playing devil's advocate, if this disease were to come back, we will figure out next steps, because there's so much going on and there's so much that can be done. And the name of the game is being around until the next best treatment strategy comes along. So, and the only way then the next treatments can be available is if we all participate in clinical studies to move the field forward. And I say what I preach. My brother enrolled on a study understanding the natural history of neuroendocrine tumors with Dr. Del Rivero and the NCI, because you and him, we want to be part of the community that is going to help to fight this disease and cure this disease. Sorry, I get emotional.
It's okay. I'm right there with you. I'm right there with you. I'm sending you all my love and light and strength, and to you all as well, everybody watching. It's been one of my life's great honors to be alongside you in this fight, and I appreciate you all being here. If we didn't get to your question, I apologize. We try our best. We just get a lot of questions, which is a good problem. And we will be back next month. But you can always reach out to Carcinoid Cancer Foundation. Dr. Soares has pledged her time to you as well, if you want to reach out to her. Dr. Soares, thank you. I appreciate you sharing that with us, and I appreciate you sharing all your insight and your passion for helping fight this fight as well. I appreciate you being here again.
Thank you so much. Love being with you guys. Take care.
Bye, everybody. We'll see you next time on Luncheon with the Experts. And thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. See you next month, everyone.